we are going to go ahead and get started. Thank you for joining us. My name is Elizabeth Aloni. I'm with Schneps Media. Schneps Media is the largest local media company in the New York metro area. We publish over 70 newspapers, magazines, websites, webinars, podcasts, and events throughout Queens, Brooklyn, the Bronx, Westchester, Manhattan, Long Island, and Philadelphia. We look forward to having you with us. So happy you're here for the webinar Alzheimer's and Dementia Diagnosis in the Aging Population. For many with cognitive decline, getting a proper diagnosis from a skilled clinician can be difficult. And in this webinar, sponsored by the Bristol Assisted Living and Berner Law Group, Dr. Absar will take attendees on a journey on how Alzheimer's and other neurocognitive disorders are diagnosed in the aging population, treating options, care services, and the importance of proactive planning. All are going to be discussed. Well, before we get started, let me introduce our sponsors. Welcome to Britt Berner of Berner Law Group. Britt manages Berner Law's Manhattan office and serves clients from New York City to the East End. Britt has been named a Super Lawyer Rising Star, a Schneps Media Brooklyn Star Under 40, an Outstanding Woman in Law by Hofstra University School of Law, and a Caregiver Champion by Caring Kind. Britt serves as Secretary of the Elder Law and Special Needs Planning Section of the New York State Bar Association. Britt also serves as a charter member of the Advisory Council of the Katz Institute for Women's Health at Northwell. Welcome, Britt.
Thank you so much. I'm so happy to be here.
Wonderful, wonderful. Welcome next to Julie Wexler, MPA of Bristol Assisted Living. Julie has spent her 25-year-plus career in a variety of elder care settings, including community-based senior services and government agencies, and for the last 8 years in the senior living industry. Her experience has inspired her to develop and support programs to improve the quality of life for all older adults. Dementia care, caregiving for older adults, and understanding elder care resources. Julie believes all seniors, regardless of cognitive or physical decline, deserve to live a full, active, supportive, meaningful, and purposeful life. My distinct honor to introduce you to Dr. Nicole Absar, Medical Assistant Professor at the Department of Psychiatry and Behavioral Health at Eastern Long Island Hospital Stony Brook Center. She is a diplomat in behavioral neurology and neuropsychiatry and board certified in American Board of Psychiatry and Neurology. Dr. Absar completed a residency in psychiatry at Tufts University Medical School while she served as chief resident. She then went on to complete her certification in behavioral neurology and neuropsychiatry from the United Council of Neurological Subspecialties. She is a diplomat in behavioral neurology and neuropsychiatry and a fellow at the American Psychiatric Association. She has a passion for integrated neuroscience interfacing neurology, psychiatry, and neurocognitive stimulation in dementia care. She's a registered yoga teacher and specialized in yoga as a therapy for brain disorders and neuropsychiatric illness. Dr. Absar will be evaluating patients at the Eastern Long Island Hospital, playing an important role in expanding Stony Brook Center. Welcome, Dr. Absar.
Yeah.
I'm now going to turn it over to Julie and Britt to have the conversation and to discuss all about Alzheimer's and dementia. Julie, Britt?
Thank you so much, Elizabeth, for the introduction. We're delighted to be here today, and welcome to all of our guests, and as well as to Dr. Absar. We really appreciate you taking the time out of your very busy schedule to provide this very important information to us. We're going to start the conversation. Tell us, what is Alzheimer's? What is dementia? How are they related? Just let's start with the basics.
First of all, thank you so much for having me. And it's really a great conversation. And I hope everybody can just relax and have a normal conversation. And we're going to try to make sure we understand this type of different terms that you use so much about dementia, Alzheimer's, all kind of different word that what does it mean? So that's a great question, Julie. Thanks for asking. What is Alzheimer's and what is dementia? So we see that all the time. We hear that all the time. So Alzheimer's, Lewy Alzheimer's was one of the greatest neuropathologists who really found out way back about some amyloid and some, neurodegenerative proteins that block in this, part of the brain controls the memory. And that was the origin of the term used by his name, Alzheimer's. And as the disease, as we get to unfold more and more, we found out those findings that Lewy Alzheimer's has found is actually clinically reproducible in a cognitive disorder, with the meaning we have different types of patient population who go through this dementia or cognitive impairment. Now we know may have certain neurodegeneration in certain part of the brain, which can cause accumulation of some abnormal proteins in their head, in their brain. One of them is an amyloid and one of them is a tau protein. This amyloid and tau accumulation is a pathological state in the brain called Alzheimer's disease. When the disease becomes clinically manifested with cognitive impairment, and that's what it calls dementia or Alzheimer's dementia. So Alzheimer's disease basically is the disease where you have the degeneration in the brain, and then dementia is the clinical syndrome. So in a nutshell, what I try to make it simple, that all Alzheimer's disease are dementia, but all dementias are not Alzheimer's. There are tons of other non-Alzheimer's dementia that we have to be careful not to slug them together as an Alzheimer's disease. So we know vascular dementia comes from stroke. We know frontotemporal dementia is another type of disease that comes in the younger population. It's a rapid progressive dementia, can involve with early behavior and personality changes, or it can involve with early language changes like aphasia as a presentation. And we also know certain other dementia like Parkinson's dementia, Huntington's dementia, HIV dementia, all kind of different names. So make sure you all understand that dementia is a clinical diagnosis, is a clinical syndrome, and Alzheimer's disease is just one cause of it. But there are other causes of dementias.
Thank you. That was so clear and so helpful to understand the difference. So if there are all these different types of dementia, what steps should someone take to get the correct diagnosis, and why is it so important to have the correct diagnosis?
Yes, so it's absolutely so crucial to have a diagnosis first, because you don't want to treat or do something without knowing what you're doing, what you're treating at, what you're treating for. So there is no one uniform fit everyone. So every dementia is so different. Every dementia needs its individual specific intervention for different technology, different medication, different intervention, even approaching differently as a caregiver. So that's why it's so important to have a diagnosis. So one of the things that I'm really passionate about is early diagnosis and early intervention. So early diagnosis means before you even have a full-blown dementia, we do see some subtle changes in person's behavior or personality or cognitive functioning. And I know the loved one and the caregiver who I'm talking to today, they will understand what I'm talking about. They have probably noticed some subtle changes in their loved one way before they actually having a formal diagnosis done. So if we can change somebody's, find the diagnosis way before you have a full-blown dementia, then I think we can slow down. We can even modify so many such clinical courses and make an early intervention so much easier for the patients and family. So yes, early diagnosis is the key. The way to diagnose is, my specialty is basically in neurology and psychiatry, so combined. So I do technology to use both neurological diagnostic tool as well as psychiatric and mental state on cognitive examination techniques. So by that, what I meant is that we find out what is the cause of the degeneration in the brain. So you want to look at the brain picture, but before we can justify that, we have to talk to the caregiver. We have to find out what is causing, what is they are struggling with. So we have 5 different cognitive domains. I'm just going to break down into so simple that everybody can understand. So we are, human, yeah? So we have this intellectual power. The way that we different from other higher mammals is we have this very highly sophisticated cortex or cortical part of the brain that makes our intellect. And this is called cognitive domains. All 5 or 6 cognitive domains comprised together will make you intellectual functioning. So one of the domain is memory, but make sure you understand it's just one domain. So you can't just have memory loss and just say dementia. You don't have to have memory as a first presentation to diagnose dementia, because it was an old way of understanding that you can't be demented unless you have trouble with memory. What a bad way of thinking, because we have so many dementia where memory is not really the problem. Problem may be other cognitive domains. So what are the other cognitive domains? So other domains includes language, the second one. Language means when you have the fluency, when you have the ability to comprehend what other people are talking to you, when you have no trouble finding the word to have a conversation. So when you have word finding difficulties, when you have trouble having a communication because of fluency, because of finding the word, finding the right word, having a communication difference, that is a form of what we call aphasia. So aphasia is the language impairment. That is the second domain. Third domain is called executive functioning. Executive function is the higher intellectual functioning that is done with the front part of the brain called frontal lobe. And this is the part that makes us think every day that what are you going to wear when you go to work? What are you going to cook when you come home? How much money you going to spend for cooking, shopping, grocery? How much money you should put up savings for your mutual fund or, stocks market or something. The planning for the future, planning for the retirement, planning for having a baby, having a pregnancy, having something, anything that we plan, anything that we have decision making, all kind of complex tasks from the dawn until you go to bed is all part of the executive functioning. So these are the sequential tasks that we do. We take it so granted that we take a towel to go to shower. We don't realize shower is not easy. You go to shower, you have to put the tap on, you got to wet yourself, and then you got to make sure you put the soap, all the steps that involve. These are called sequential tasks. So when you have executive functioning impairment, you may know that you have to take a shower. You'll be having difficulty continuing what step comes what after that. This is called multitasking purpose. Yeah, multitasking instruction. And that is one of the part of the executive system. So this is the domain for executive functioning. The next domain is called visuospatial function. Visual means vision, spatial means space. So this back of our brain and the side part of our brain, this is the brain called visual brain and spatial brain. Visual brain basically process what you see through the eye, and the spatial brain tells you what you see. So if I look at Julie, my eyes take the picture of Julie, send it to my visual brain, and my visual brain then process the picture. Like the old days, they used to do picture in the black and white photos. Remember the photo lab? They used to do all the picture. This is the photo lab in our brain. And that photo lab process the picture and say, okay, that's Julie. I know. Then it asks the spatial brain to say, hey, I understand it's Julie, but where is Julie located? Is she in front of me, or is she through the computer talking to me? Spatial brain then tells you, yes, you are in your own home or own office, you're doing a webinar, and Julie is on a different area of maybe in her own office somewhere else, but she's also connecting to the webinar. So this is the spatial brain is the part of the brain, geographic orientation, where you are, location, everything that we take, orientation, this is the part that does it. So this is another domain that we need to find out if somebody is having struggle with, And then finally, also object recognition, face recognition is a big domain that we can recognize our own children. We can recognize our own, known people, familiar people's face. We can recognize what you call a pen, a watch, a bracelet. What do you call this object? These are the object recognition. So all of these are different cognitive domains. So when I see a patient, after talking to the patient's family, I wanted to find out from the caregiver, from patient's next of kin, tell me how the disease started. You know your loved one so well. Tell me which came first, because we need a step-by-step report. Because if I take a good history just by talking to somebody, talking to the family, like which came first? Was the memory came first, or the word finding difficulty came first? Was the driving difficulty came first, or the memory came first? Because that way we can pinpoint the diagnosis more clearly. So taking a good history, talking to the caregiver, and then doing the cognitive exam that I'm doing with all 5 domains that I talked about, testing for each of them clinically, one by one, and then formulate a form of differential diagnosis like, okay, can it be this? Can it be this? Can it be this? And then to validate my diagnosis, I go for a blood test first. And the blood test will rule out a lot of the medical condition that can look like dementia, like thyroid gland, little gland here. If you lose a hormone level, you have a low thyroid, underactive thyroid, that can look like dementia. You have a vitamin deficiency like B12, vitamin B12 deficiency, folic acid deficiency, simple things like that, that can look like dementia. You have so many things that can look like dementia. So we need to rule those out. So do the basic blood work, and then we do a brain scan. And the brain scan will be like a structural brain scan, like a brain MRI or a CT scan, where you can rule out if you have any bleeding, any hemorrhage, any tumor, anything like a structural difficulty. Then I also order a functional brain scan where you can measure the function of the brain. We call it FDG PET scan. It's a form of PET scan, PET, PET scan, that people diagnose different cancer. Now, actually, we diagnose dementia with the same scan. And that can diagnose, pinpoint different neurodegeneration in the brain, like Alzheimer's disease, Lewy Body dementia, frontotemporal dementia, psych lag. So these are the comprehensive evaluation that we have to go through or finalize a diagnosis of dementia. Hope it wasn't too long, but I just wanted to make sure I covered everything from the basic talking to someone when the interview date until you formalize a diagnosis after doing all the testing and everything.
Yeah, no, it wasn't too long. And I think what it really did was underscore how important it is to go to somebody who's a skilled clinician and is able to go through the steps that you go through in order to get a proper diagnosis. I believe we do have actually an image of the brain to share, which might help the audience sort of understand these different parts of the brain that all have their own little job to do, and so that we can understand that when different parts of the brain are affected by a disease process, it can cause the different symptoms that we see. So tell us a little bit though, and I know this is a very broad question, but how do these diseases affect day-to-day functioning? And I know another challenge that many of our families express to us is driving. That's always one that's a big safety concern. So can we talk a little bit about that?
Absolutely, absolutely. I'm so glad you brought up this picture so I can actually walk through. Hopefully everybody can see the picture of the brain. So if you look at, I don't know if you can see my arrow, the front and this is the back. So this is the back of the brain. This is the front of the brain. Front of the brain starts with the frontal lobe, which is the area that I talked about, the day-to-day functioning, like what they call executive function, focusing ability, attention, ability for feeling good, mood, motivation. These are the part that does it every day. And then the temporal lobe, which is the purple, not purple, there's a little pinkish hue there at the next door. I don't know if you see my arrow here. That is the home of our memory. That's the memory part called hippocampus, which is the learning part of the brain, retention part of the brain, memory part of the brain. So that is what the Alzheimer's disease start here. So Alzheimer's normally start here in general, and it goes into through the visual part, which is the back part of the brain that I was talking about when I was mentioning, I see Julie and her picture goes into my visual brain. This is the brain I was talking about. It's called occipital lobe. This is the processing of visual information. And then the yellow part is the parietal lobe. That's the spatial brain. We call it where pathway, meaning where is everything? Where is Boston? Where is Florida? So this is the part tells you where you are. This is the part tells you when you drive that whether you should drive 95 north to Boston or 95 south to Boston, whether you go to 95 north to Florida or south to Florida. So this is the part tells you. If I'm driving for 20 years, but my parietal lobe doesn't work, it doesn't matter how good I'm a driver, I may take 95 south, end up in Florida. So this is the major area in driving. So driving involves this parietal occipital cortex. This is the area called where pathway. Where are you going? Where is the object? Where are you located? All the geography, all the location, all the orientation. And also this is the part make you understanding the depth perception. So if you're driving between two lines, that your perception, whether if your car is in between two lines, if your car is too close to another car, how far are you from the curb? How far are you from the another car? So this depth perception is maintained by this part of the brain. This is also the part which controls opposite field of our body. So if you lose the right side of this parietal cortex, sometimes you can lose the vision of the left side. They call it neglect syndrome. And, I always give a simple example sometime. And I would like to give you an example. And this is a learning example for me. And I'm hoping that anybody who works in healthcare and as well as a caregiver can find this really useful, this example. So this is what I was working in my previous job in Hopkins in Maryland. And when I was working there, we had an assisted living facility connected in the Hopkins network that I was working. So one day I got a phone call from the nurse from the assisted living facility that, oh, Dr. Absar, I need a medication, Ativan, something really bad. One of my patients is really acting out. She's eating from another patient's plate every day. She doesn't eat from her own plate. She grabbed food from her neighbor patient's plate, and the neighbor resident is very angry because she's like, oh, why don't you eat your own food? Why you have to take my food? And they fight, and I need a medication to calm her down. So I'm like, okay, but I don't like to medicate unnecessarily. So I said that order because before I start medication or giving an order, I want to examine, I want to see her. So give me 5 minutes, I'm going to be over in a minute. So I went there, I walked there, and I said that, all right, come over. What happened? So she's like, well, she eats from other residents' plate. I said, does she always eat with the left-sided resident, or she always also take food from the resident sitting on the right side? She said, no, she always eats from the other side, left side. I said, oh, that's interesting. She doesn't need bother someone sitting on the right side, yeah? So I said, okay, let's bring some paper. So I brought some paper. I had some testing, which is a simple test. Sometimes you can draw a clock and you can really diagnose this neglect syndrome by looking at a clock. When you draw the clock, they draw everything on the right side, completely neglecting the left side of the the circle. So she did that. Then I have something called line bisect test, which is you draw a line and you ask them to find the midpoint of the line and bisect the line or cut the line right in the middle. This lady cut the line way away from the middle, meaning she has severe neglect syndrome. That's why what was happening, she was seeing half of her plate and she was seeing the other half of the other left-sided resident who was sitting on the left side, her plate as her own plate. So what she was eating is taking half of her plate and half of her other patient. So it wasn't her fault because she thought that's her own plate she was eating it. So I told the nurse that, you know what, she does not need a Ativan medication. You guys need education because if you wanted to take care of someone with dementia, you need to understand what is neglect syndrome, because this can cause so much behavior issue. And then you end up calling somebody for medication unnecessarily. But if we could arrange them not to give us a little bit of space between them, so she doesn't have to eat from somebody else's plate. And they did that. They rearranged her sitting arrangement in the dining room, and she was fine after that. So these simple things can have so much intervention. So this is the area that does it. And then we talked about the frontal lobe. This is the part, sometimes we get fixation on that part because this is the part does multitasking. Remember all the moms, here and there, how we take care of our kids and do work and everything. We are multitasker, yeah? I'm just kidding. Everybody does it, but I'm just giving credit to the moms. But it's hard. Yeah, multitasking is not easy. This is the part that does it. So when you have someone with dementia, especially with frontal lobe disturbance, you can't expect them to multitask. So if you give a complex instruction, it's too much for them. You can't tell them, take this towel and go and have, put something, wash yourself with the soap and change your clothes and come back from the bathroom after an hour or so. It's too much information. You have to do one step at a time because this is the multitasking. We have to be their frontal lobe. So this is why they go to assisted livings, because assisted livings provide the artificial frontal lobe for them. So they provide the instruction, reminder, prompting. How do you do? What do you do? One step, so that everybody can have a good quality of life, a good way of meaningful life. So this is all the things that can be so much nicely done if we can understand the brain part with their behavior part. So don't jump into the behavior. Find out what is causing the behavior before we treat with a pill.
That's such great advice, and we really appreciate that. And you touched on a little bit about psychiatric symptoms, and that's one of the biggest challenges that families face, and I think that we face in assisted living as well. So can you share a little bit more about the potential for psychiatric symptoms for folks with dementia?
Absolutely, absolutely. One of my passion is a dementia called frontotemporal dementia, because that's such a sad disease. I mean, every disease, every dementia is sad, but frontotemporal has more sadness. At least Alzheimer's, we know that we pretty much good with diagnosis, but frontotemporal dementia, we still miss the diagnosis because this is one of the dementia that present with early either language or the behavior as a presentation. So they never have trouble with memory or other cognitive functioning. They're fine. So if you do a memory testing, they score 30 out of 30. They don't have any trouble with memory. So people think, oh, they're not demented, but family feels, oh my God, they cannot. So I'm just gonna give you an example of first. This was my early days after my fellowship, training in Cape Cod, Massachusetts. I was opening up a practice in Falmouth, Massachusetts. It's a beautiful waterfront, oceanfront property I was working at an assisted livings. So this was a gentleman I'm talking. So I'm going to share a little example about so that you can really relate what I'm talking about, the story. This was a 56-year-old gentleman who was a chief of police department in Cape Cod. Very, very obedient, loyal police, he never even have any, a lot of police may have not good conduct, but he's a very efficient police and loyal to law and obedient. His colleagues noticed that he started acting a little bizarre. He coming with a, Cape Cod is a nice summer town, a lot of people wear shorts, but he was coming with a really scrappy shorts at work and not really appropriate dress with a sandal sometime. And he was talking a lot of F word at work, and touching female colleagues inappropriately sometime. They thought, men has a little bit of excuse in their 50s because they think it's a, what do you call it? Like a aging thing, or it's a midlife crisis or something. So they thought, oh, well, he's going through midlife crisis or something. It's not a big deal. So it went on. People just, sugar-coated everything. That's fine. It's nothing. Until he started harassing his ex-wife to a extent that he raped her in front of their little grandkid. So, and he broke the entire house, he had so police came and they arrested him with the assault and battery charges. He went to a correction facility in Massachusetts called Bridgewater State Hospital. It's really not a hospital. They call it Bridgewater State Hospital, but it's really a jail. The reason they call it hospital, because at least they had a psychological evaluation. Every criminal has a psychological evaluation to see whether they can stand trial, whether they have any insanity or any kind of defense for insanity. This poor guy never even have a psychological evaluation. Forget about any neuropsychological. We're not even talking about that kind of sophisticated test, not even just basic psychological evaluation, because they treated him like a criminal, which he was. He did a bad job. He raped his wife, he did all the vandalism and all kind of. So they jailed him. So he was in jail for 4 years. After 4 years, he got released, and they found him right in front of Cape Cod Hospital in Hyannis. He's sitting in front of the hospital. He's cutting his wrist with a knife, like an impulsive manner. People now say, oh, what do you expect? He's just depressed. He lost his job. He lost everything. He's just depressed. So now they take him to the psychiatric hospital. So they admitted him. They got the diagnosis of major depressive disorder. They gave medication that didn't work. Then they diagnosed him with schizoaffective disorder. Nothing worked. In the meantime, Cape Cod is a nice place for resident to moonlight, to make some extra money. So there is a resident who's resident in psychiatry coming from Harvard Medical School in Boston. They come to Cape Cod to make some extra money. And if you come for the weekend, they put you on the oceanfront hotel, you have a great life, and you make some extra cash. You go back to Boston on Sunday night. And, so this young, very smart resident comes to Cape Cod for moonlighting, and he saw this gentleman. And he is the first one. He said, this is not psychiatric. This is something wrong with this patient neurologically. So this is how I got this patient referred next day. So when I start seeing this patient, oh my God, patient has severe executive function. Remember the frontal lobe I was talking about. Severe, what is the part of the frontal lobe called, just above the orbit is called orbitofrontal cortex, meaning orbit is here, frontal lobe is here. So this is the area between the orbitofrontal cortex, which is our behavior part, repetitive behavior, aggression part of the brain. And so he had so much sign of frontotemporal dementia. So I sent him right away to the, they didn't have PET scan back then. They used to do SPECT scan, SPECT. We don't do that anymore because now Medicare actually reimburses PET scan. So PET scan is much better than the SPECT. But I did the SPECT scan, and the neuroradiologist called me and he's like, Nicole, you got to come right away where you are. I'm like, why? Is my patient okay? He's like, yes, just drive, come to me. So I drove like crazy. I'm like, why is calling me to go? I went there and he's like, I have never seen a scan like this. Can you tell me what is it all about? I said, what? I look at the scan, his frontal lobe has, so SPECT scan is basically a perfusion scan. So you had a blood perfusion in the different part of the brain. Remember the brain picture that Julie was showing us before. So normally, if you have a healthy brain, you should have perfusion throughout the cortex, throughout the brain. He had nothing in the frontal lobe and the temporal lobe. So it's like I have never seen such a severe hypoperfusion in the frontal lobe. So with that, I calculated that he's in a severe kind of last stage of frontotemporal dementia. Frontotemporal dementia is a rapid progressive dementia. People die within about 8 to 9 years in general. So think about, he was in jail for 4 years. They misdiagnosed him with this midlife crisis for a year. They didn't pay attention. So he probably had a 2 or 3 year left. So I immediately ran out and called the family. He had 2 beautiful daughters, like they are in their 20s. They come, they have no idea he has dementia. Nobody even know. And this is all of a sudden. So they're crying so after diagnosis, he actually died within 2 months after I actually diagnosed him, because frontal lobe controls our swallowing. So most patients with this type of dementia die from choking episode or, swallowing related problem. So the moral of the story was, this is what happened because this dementia present as a psychiatric symptom. This dementia present as a psychiatric problem. Similar to that, there is a dementia called Lewy Body dementia, where memory is not the problem. Problem is they start with visual hallucination. They see things, they kind of have delusions and hallucinations so much bad, they actually see them so intensely. And that they can also have some Parkinsonism and some confusion, and also have difficulty, a dream-like phase at night. They call it dream enactment behavior, meaning they act out of the dream. And the funny thing is, you can ask their partner, do you guys sleep together? They're like, no, hell, I'm not sleeping with him anymore. And they're like, why? He's like, he's been kicking me all night long. Why would I sleep with him? And then that's what happened in dream enactment. They kick the partner because they think they're fighting with somebody in their dream. So whoever is next to them, they are just punching, kicking, and sometimes they fall out of the bed because they're fighting in their sleep. So those are the symptoms of Lewy body dementia, not memory. So their memory is not the problem. And then vascular dementia is another from the stroke. In vascular dementia, memory is not the problem, at least initially, and their problem, we call it syndrome of 3M. That's what I make in mnemonic so that my resident and my medical student can remember. So this 3M, first M is not really memory. First M is the mood. Their mood becomes the first problem. Depression is the first presentation of vascular dementia. Apathy, lack of motivation, like a feeling sitting there like a zombie, not doing anything all day long. And so sometimes they can be apathy, which is not depression, or they can have a depression. So they can have both. And then they come with the second M called movement, like gait problem, like walking problem. So they started falling a lot. And then they start the memory, but their memory is only short-term memory, not long-term. So they're very different than Alzheimer's disease. So that's called vascular dementia. That also start as a behavior presentation. So the behavior, mood, hallucination, that can be a presentation of so many dementia. So that's why it's so important that we have to monitor if anybody who never had a psychiatric symptom in their life or psychiatric diagnosis have a late life depression in after 50s or 60s. It is well known that that kind of depression, even without dementia, is mostly vascular depression, meaning they actually have a lot of microvascular disease like cholesterol plaques in their brain. So definitely, I would definitely need an MRI if somebody has that kind of late onset depression, because that can be the early presentation of their vascular dementia. So that needs to be done. They need to have a neuropsychological testing or some kind of cognitive evaluation and an MRI. So make sure they don't just think, oh, it's just psychiatric and just see a psychiatrist, not have anything to do with the neurology or cognitive finding. So that is dangerous. So yes, I'm so glad Julie asked me this question, because this is really, really something always need to be, for the caregiver to monitor that if there is any abnormal personality changes, that somebody was very reserved or like a what do you call it, introverted, or now all of a sudden they become like a social butterfly, they become like a personality change, such a 180-degree change. That's an early sign of frontotemporal dementia sometimes, or very sociopathic behavior, criminal behavior, or sexualizing behavior, or sexual disinhibition, like not having any filter, talking like a F-bomb everywhere, or like touching inappropriately, especially females or male, or in any sexual manner. So those can be a what they call disinhibitory behavior. That can be the early presentation of this type of frontotemporal dementia. So there's a lot, I mean, it goes on and on, but it's a great thing that we should always monitor. So that can be presentation of dementia, but dementia itself will also come with psychiatric symptoms. Like Alzheimer's disease will have lack of dopamine, lack of serotonin. So that can cause severe OCD, like a hoarding behavior. Then they start hoarding, and that's very interesting. One day I could not find my beeper when I went to a Boston hospital, and the nurse was smiling. I said, "Why are you smiling?" She's like, "You didn't lose your beeper. We know exactly where it is." And she went there. She's like, "It was Mrs. Smith's house. She just hoard everything she get." So the hoarding behavior is very common in Alzheimer's disease. It's an OCD, obsessive compulsive behavior. Sometimes they have a repetitive behavior like a skin picking. So to an extent that they make a big ulcer in their skin, and that can be dangerous for infection control. So this kind of compulsive behavior, hallucinations, delusion, these are all part of the dementia. It can be the presentation of a dementia, but it can also be the manifestation of different symptoms of dementia.
Now, Dr. Absar, that's so much information. There's comments flying in about how clear it is, and I can't agree more. Everything that you're saying, the examples you're giving are great. The examples you gave about the woman with her plate, and we heard about how you have, you're a yoga instructor and you use that in your work. So it's clear you believe in a holistic approach to your patients. Can you tell us about how you approach your clients and your patients and the work that you do at the Center of Excellence?
So absolutely, I think we have to have an integrated neuroscience kind of perspective, because these are the disease, we don't really have an answer for it. We don't have a cure for it. We have to treat the person as a person. We cannot just generalize. And one of the things that I just feel traumatized by this healthcare in our country, we have a disability-based healthcare. So we do not have insurance company approved for a care for gym membership or nutritional consults, but they will approve once you have diabetes. They will approve you all the care that you need after you develop diabetes, but they're not going to give a gym membership or dietary consultation reimbursement so that you don't get diabetes. So we don't have the prevention. So we have to start looking at how can you slow down? How can you empower the patient and caregiver? How this diagnosis, all the different neurodegeneration still can come up with the self-empowering power, a positive in the end. I'm very optimistic, doctor. I really feel like we have to share the optimism with our caregivers, because it's draining for our caregivers to live with something and, someone loved one and see the decline every day. One of my caregivers, patient's caregiver once told me, after he died, she said that, well, he actually died 5 years ago. He was there physically, but he wasn't really there. So I already believe, having grieving since 5 years ago, which is so true, so it's so hard for the caregiver to go through this. So we have to have this optimism. One of the things that after I do the PET scan and MRI, I share a optimism by my third hat, which is the yoga hat. So I said that, all right, you heard about my neurology hat, you heard about my psychiatry hat, I'm going to pull out my yoga hat, which is the mindfulness and spiritual hat. And this is what I share with them. A spiritual God, Buddha's mantra, one of the things that Buddha said before he died, he said, you're not going to take anything to the grave. There is only three things matter in life. Number one, how much you loved. Number two, how gently you lived your life. And number three, which is the hard one, how gracefully you let go things that does not serve you anymore. So I share with the family that look at you, you have loved by your family. They are all here for you. Look at you, you brought up your children, you went to school, you went to college, you worked hard, you had a gentle life for all your life. And now don't fight with the diagnosis. It is what it is. Just accept the diagnosis and focus on, okay, I understand the PET scan that showed Alzheimer's disease, but what can I do? How do I challenge my brain? What do I do more to slow down the progression so that I can have a good quality of life for the rest of my life for me and my family? So this is what comes the cognitive health. Cognitive health comes with three components: diet, physical exercise, mental exercise, and cognitive exercise. Diet, there is a specific diet that has been well researched in neurology called MIND, M-I-N-D. I hope we can Google that in the future and share with our caregiver. MIND stands for, is a hybrid diet, is a combination of two diets together. One is called Mediterranean diet, and one is called DASH, D-A-S-H, which is a hypertensive diet, blood pressure diet. Mediterranean diet, people in Italy and Greece, we all eat that, but it has a lot of pasta and rice in it, carbohydrate, yeah? But it has good fat, like olive oils, like, all the good fat there. So they keep the good fat, but they eliminate the bad salt and carbohydrate by hybriding this DASH diet in it. So the DASH diet is a low carbohydrate and low salt diet, and Mediterranean diet is a low LDL, which is the bad cholesterol that comes from the red meat and the butter and margarine, all the good stuff. And then the high HDL, which is the good fat that comes from the olive oil, coconut oil, omega-3 fatty acids, salmon, all the fatty fish, eggs, avocado, all kind of good fat, which is good for our brain, good for our heart. So this MIND diet, they did a 3-year study. It was a big study in Scotland, 963 participant study. They had an MRI in the beginning 3 years of the study, and they had an MRI after 3 years of the study to compare. They put them into two groups. One eat just MIND diet food, one ate everything else. And in the end of the study, they had an MRI, follow-up MRI. They found out amazing result. They thought that people who ate the MIND diet, their shrinkage in the brain was decreased comparing to the other group. So this is what the American Academy of Neurology actually recommend MIND diet for neurodegenerative disease like Parkinson's, like Lewy Body, Alzheimer's. So it's a great food. So that's cognitive health for the nutrition. And then physical activity. If you can daily walk, that's a great exercise. If you can do some cardiac exercise, that's good. But if you can't do it, just walking. If you can't walk, if you only have trouble with the walking, just do chair yoga. Chair yoga is a great technique. You don't have to move. You can just move around and do some exercise. It's fun. Yeah. You can move around and do some physical activity to burn calories. That's really, really good for your heart. Whatever good for your heart, good for your brain, slow down the Alzheimer's disease and any dementia. And then the mental exercise is the reading. Daily reading is a really good thing. Reading something interests you, and then finally the cognitive exercise is brain game, any kind of games like crossword puzzles, any kind of computerized game or anything is a really good. So if we can do that to empower ourselves that, who cares I have the Alzheimer's? I would not let Alzheimer's disease define who I am. I'm going to be who am I. I am going to always be who I am, not defined by a disease. and then just believe in that and slow down the progression. So instead of sitting in the couch all day long, you can maximize your loved one to do brain activities, to do brain exercise, eat that mind diet or healthy brain food. And so this is how I think, in addition to the medication to slow down the disease, we can all do. And if we can combine together, then of course, the disease can be slowed down. And finally, one last thing I wanted to empower again. I'm so much looking forward for the cure of the disease. I mean, we're very close. We're really close. We have a lot of disease modification therapy coming up. So this is the time not to give up. Not to give up at all. This is the time to go for it, struggle and find out how we can maximize our brain power and brain activities to open up these collateral neuronal channels. More you do brain activities, more, this kind of channels open up. This is so true. They thought about, brain doesn't regenerate. Well, it's wrong. Brain doesn't regenerate, but it's a synaptic transmission can open up. We can actually improve our, almost like a rehabilitation to some extent, to improve the functioning, slowing down the disease to some extent. And also it helps with the overall quality, overall depression, overall mood, motivation, that helps. So I wanted to see that near future someday when people will go to wellness visit in their 40s, even 30s and 40s, like we go for mammogram or we go for colonoscopy, and then primary care physician will order this amyloid PET scan, which is another PET scan that is yet not reimbursed by Medicare, but it's going to be soon will be reimbursed, that actually can see the picture of amyloid in the brain, which is even more better for diagnosis for the future. So they can order the scan. And if you have a positive amyloid scan, then either we can start the treatment and put you on this cognitive health that I was talking, diet, exercise program, and then Alzheimer's disease will be a history.
From your mouth, that is so amazing to hear. You are simply incredible. Thank you so much for this information.
Thank you.
And you made it so simple for people to understand and really hit so many key things that we need to know, and also given us so much hope. So thank you so much for that. I want to ask Julie and Britt, what made you want to sponsor this program? Why was this so important to each of you?
So you may know that 25 years ago, I was a caregiver for my father-in-law, along with my husband, and he had many of these psychiatric symptoms, and we were a young married couple, and it was incredibly stressful. And fast forward 25 years, I hear Dr. Absar do a presentation, and finally I was like, that was the form of dementia that he had. And so Dr. Absar just had an incredible way of making it make sense. At the Bristal Assisted Living, we work as a team. We're just a piece of the puzzle in terms of supporting families in managing the day-to-day life of their loved one and finding the right supportive care and the quality of life that they deserve. And having doctors like Dr. Absar as a team member and getting the right diagnosis, and not just writing the prescription, but making sure that the family is getting the support that they need and the resources that they need, and have the hope that she's offering is just so invaluable.
Yeah, at Burner Law Group, we are trust and estates and elder law attorneys, and we're dealing with a lot of clients and their caregivers as they approach different phases of a loss of capacity. And it is a lot of gray area, and we try to find things early on, as Dr. Absar is saying, and we've always had part of our mission be to bring awareness and education to the communities we live and work in. And so by teaming up with all of you today, we really are trying to continue that mission and bring amazing information like everything Dr. Absar just told us, so that we can get closer to that cure that I'm so glad, as you said, Elizabeth, to hear Dr. Absar feels like we're on our way.
Thank you. Thank you for caring and sponsoring something like this. This is so meaningful and impactful. And I do want to get to some of our questions. As you mentioned, so many of them have come up, and I know we've been here for a while, so hang in there because nobody wants to miss a minute of this. Dr. Absar, I do have some questions for you from our attendees. Rebecca said, what are the early signs that indicate one should get a diagnosis, and how early should we be alert to these problems?
So as I was saying, earliness is a relative term. So, I mean, don't delay, don't just say, it's just getting older, Now we know the aging should not cause cognitive slowness, cognitive delays. There is some, little bit of brain fog we all have sometimes. It should not it should not interfere every day functioning. Sometimes when you're stressed out, we all have some, I don't remember what I was thinking. That's not what I'm talking about. If you know what exactly I'm talking about, when you have trouble finding the word in a communication, when you have trouble remembering things, when you're losing things constantly, misplacing things constantly, accusing other people that they are taking your stuff instead of you losing it or misplacing it. And then, if you have trouble, you're driving familiar places for a long time, now you have trouble getting direction, getting the GPS running, understanding, you yelling at GPS lady because you can't find the way. And you have a trouble. You know that this is not normal, that you've been with the same road every day. Now you're missing the exit, So I'm not talking about unfamiliar places that we all get lost sometimes, but familiar places driving. Or if we have trouble with managing money, we not utilizing our brain power to manage. So we're writing checks inappropriately or not even knowing what I'm writing checks for. So those are the early signs that especially problem I find. And again, I am not putting any couples, in a hard manner or anything, but I think it's very normal when you lived with somebody as a couple for a long time, you may miss those because you are so used with each other. So husband and wife sometimes is not the best historian. That the children comes the best historian because they are not living with them. They come sporadically and see them. Oh my God, my dad, what do? You were not like that last time when I visited for Thanksgiving. Oh, mom, have you seen dad doing that? Or dad, have you seen mom doing it? So I think it's a collective history from a family, don't minimize, don't say, oh no, he's just depressed or it's just too much stress going on. That's okay. 1 day or 2 days you can minimize, but if it's persistent, then don't delay. Get a primary care physician evaluation first to see, and most primary care physician can do basic screening, and they are able to do mini mental state examination. They have a lot of various screening they can do right away. If they feel comfortable, they can even order a scan right away, or they can just refer someone like us, or even a general neurologist, whoever, just get a good evaluation done. And so those are the symptoms. It's not one symptom fit for all, because remember I said 5 cognitive domains. Each of those domains is different direction. So Alzheimer's is not going to be same as frontotemporal dementia. Frontotemporal dementia is not going to be same for Lewy body dementia. For Lewy body dementia patient, if you see someone with a visual hallucination, little bit of Parkinsonism like tremor, or little bit of confusion, nothing to do with memory, but confusion with like a sluggishness in the daytime, not doing anything, and then having this acting out at dream at night, talking loudly or screaming at their sleep, or that can be the earliest sign of Lewy body dementia. So you should get help during that time. So it's all depending on each type of dementia I'm talking about. The signs and symptoms is not going to be same. So for Alzheimer's, it might be the memory, misplacement of object, accusing other people, finding the word, having a conversation, Whereas in frontotemporal dementia, it can be just the language, or it can be just the behavior, like the way I talked about the Cape Cod co-op. He just had a change of personality and behavior. Or it can be Lewy body with a Parkinsonism, or, like a tremor, or the hallucination and this intermittent confusion, like a fluctuating confusion. So if you see any of those, or if you see late life depression, all of a sudden patient is getting not so much depression, but more what we call apathy. Like if you ask them, are you depressed? They say, no, I'm not depressed, but they're not doing anything. They're just sitting there, zombie, like a zombie. They have nothing, staring at the window all day long, nothing. And that is called severe apathy. Apathy is a lack of dopamine. And it's actually treatable. It's actually, you can start a dopaminergic medication and it's actually 100% treatable. So some of the symptoms are really treatable that can improve the quality. And that's why you need to have a doctor assessment early as possible. No one deserves to suffer, okay? Everybody needs a good quality of life. So yes, don't delay with the diagnosis. Have your primary care physician get referral as soon as possible, or at least talk to the primary care whenever you have a concern or question about anything.
That's really good advice. Thank you. Can you just quickly run through the 5 cognitive domains? Because someone said, what is the 5th? But maybe you can just go through those quickly.
Sure. So it's sometimes I can have 5 or 6, but most of them are the major ones. The most first one is the attention and executive functioning. This is the biggest one that we need every day to work as a human. Yeah, multitasking, working as a mom, working as a corporate manager, all kind of stuff, decisions. So executive function is the number one. Memory, you will never forget the memory. Language is the other one. Visuospatial, like a vision and spatial. So trouble with the vision, because remember, I cannot emphasize more about a type of Alzheimer's. I think I didn't touch. There are 3 types of Alzheimer's disease. Now we know only one type of Alzheimer's actually present as a memory as a first presentation. So don't get fooled if somebody has a genetic history of Alzheimer's disease in the family, but they have trouble with language, or they have trouble in seeing things properly, or driving properly. Because there are 3 types of Alzheimer's disease now we know. One, the most common form, which 60 to 70% or even more, the most common form is the amnestic form of Alzheimer's, meaning you get memory problem. We all know that. Second one is actually called logopenic Alzheimer's, meaning they don't have memory as a first presentation. They have trouble with the word finding, with the language in a communication. Third type of Alzheimer's is called visual variant of Alzheimer's, where they go to eye doctor rather than a neurologist or neuropsychiatrist, because they think their eyes is the problem. They can't see properly. They misperceive something, roof, like a, what do you call it? Like a, something, misperceive things. They can't process visual information properly. So everything is different. So even with Alzheimer's disease, these are very different. So the domains with the executive function, memory, language, visuospatial function, and then of course these learning, motor learning and recognition. Motor learning is like when you were a child, we learned how to walk, we learned how to swallow, we learned how to button our shirt, we learned how to tie our lace of our shoes, we learned how to put the earring in our ear. When you unlearn it, meaning when you go back to before you learn things, that's called apraxia. So apraxia, A-P-R-A-X-I-A. Apraxia means almost like going back to the child, that now you don't know how to button your shirt anymore. You don't know how to lace your shoes anymore. You don't know how do you comb your hair anymore. You don't know how to put, things in the microwave or things in the kitchen or things like that, that even in extreme case, we have a hard time swallowing because we put the food and we pocketing food in the food because we forgot what to do with the food once you put food in the mouth, because they call it orolingular apraxia, meaning they have trouble with swallowing because they forgot how to swallow, so this apraxia is a symptom of dementia. and then recognizing object, recognizing people's name, face, they call agnosia, or face recognition, object recognition, like recognizing your own children, own family members. So those are called agnosia. So those are the domain. So the memory, executive function, visual spatial function, and then language. Have I missed anything? And then
I think you got it. I think you got it. You're terrific. I'm gonna ask just a couple more questions that we have. I know people are chomping at the bit. So someone was asking about B12 and memory and about prevention. I know you talked about diet and exercise. Do you know, what do you recommend about B12? Is there information about that that's credible?
So B vitamins are, I call it memory vitamins, because they are very good for cognition or cognitive functioning. Because, you know, if I was not a doctor, I would be, the next subject I would go for is biochemistry, my favorite subject. So in a biochemistry, most of our chemical reactions in the brain is catalyzed by a couple of cofactors. We call it coenzymes. Magnesium is one of the coenzymes, and vitamin B1, B6, these are also used as a coenzyme. So when you lack of these B vitamins or a little bit of B1 or B6 or B12, and depending on what kind of reaction you're talking about, or even element like calcium, magnesium, that minerals that comes with the food, then your reaction doesn't happen. So remember, brain is all about protein, yeah? Because Alzheimer's, what is the cause of Alzheimer's? So far, we don't know exact cause, but what we thought that we're thinking is that this abnormal accumulation of protein called abnormal protein called amyloid and tau, which is in a mutant form. So it's a genetically altered conformation. That's what they get trapped in the brain. They can't get out, yeah? So because we're talking about this protein, we're talking about serotonin, which makes us happy, dopamine makes us love someone or do something, you know, and acetylcholine, which makes us memory, glutamate, which makes us learning new information, and, you know, all kind of chemicals come from these chemical steps. So you are what you eat. Okay, so this is the old word, but it's so true, because you have to think about brain food. You have to supply the brain food to eat every day, because you have to remember these brain food, they call it essential amino acids, meaning they don't synthesize. You have to supply from outside. So you got to eat brain healthy food. And then with this catalyst, that magnesium, vitamin B1, B6, they can catalyze those reactions to make serotonin, dopamine, melatonin. Melatonin is the reason for sleep, reason for this sundowning, like people get this circadian dysregulation. Is the evening comes, all the agitation starts in the evening after 1 o'clock. So if you go to a nursing home in the morning, everybody, so gentlemen and women, they are like, no noise. If you go after 3 o'clock or 2 o'clock, oh my God, it's a different story, yeah? Because it's sundowning. Sundowning is the biggest problem for the caregiver. And we have so much nice way we can make it better. You cannot cure anything, but at least we can make it so much bearable and improving the quality of life. So yes, B vitamin we do as a part of the workup. We test them, B12 level, folic acid level, something called homocysteine, which is another chemical for elevated like a lack of B vitamin deficiency sometime, and you can treat them. So yeah, so supplement, you don't need a supplement if you really eating healthy diet and, you know, in moderation, most of the diet. But with the food that we don't know what are we eating, I think it's nice to have some kind of supplementation of vitamins and minerals, and make sure drinking plenty of fluid, not too much water, because too much water can dilute your sodium, and that makes you more confused, more dementia-like symptom. So that's not good either. But adequate water intake, because dehydration is not good. Too much hydration is not good either. So dehydration can make you what they call delirium, like a medical form of dementia-like symptom. So we have to really understand what is delirium and what is dementia. So delirium means an abrupt change. Somebody who was doing fine, all of a sudden they are severely confused, you know, like an abruptly. That's not dementia. You need to, that's an urgent care need. You need to take them to the emergency room right away to have them, make sure they are not dehydrated. If they are, they need a IV fluid. Make sure they have no urinary tract infection or pneumonia, because that needs an IV antibiotic or oral antibiotics right away. Make sure they don't have too much drug-drug interaction or some kind of toxins in the brain. So they need a toxic screen done in the blood examination. Make sure their sodium is not too low, especially in a summer day when we're not drinking enough water. Make sure the kidney function is okay. Their urea and creatinine level is good. Make sure their liver enzymes are good. So I always ask, even someone with dementia, make sure you understand what is the usual symptom of dementia for long term and what is delirium, meaning dementia symptom doesn't abruptly get deteriorated, okay, in a day. It slowly progresses. When you see someone with an abrupt confusion or abrupt unsteadiness or abrupt hallucination or abrupt, anything abrupt change in mental state, call 911 or call the primary care doctor's office.
Thank you. You are phenomenal. Thank you. So we could literally stay here this entire afternoon and ask you questions, but we will respect your time. But thank you so much for your generosity of spirit, for your incredible information, and for your beacon of hope. Really, you're a very special individual, and really drove home to us how important it is to seek out professionals in your life. Be able to find the right medical professional. And then also, you know, a huge thank you to Britt and Julie to be here. You know, how important it is to find the right team, you know, whether that's for your estate planning, the Burner Law Group. I actually put their website right here in the chat. And reaching out to Julie and her team at the Bristal. I included that email as well to discuss what are the living options and, you know, what are the care options, and making sure that you have the right team for yourself, for your loved ones. Don't put these things on the back burner. Make sure that you're addressing them and that you're addressing them fully. So we really had the trifecta here. Thank you, Britt. Thank you, Julie. Thank you, Dr. Absar. Really extraordinary. As I mentioned in the chat to everyone, this has been recorded. The recording will be available to you within 24 hours. We will email it to you, as well as you will be able to find it on the YouTube Schneps Media YouTube channel at youtube.com/c/SchnepsMedia. We appreciate your spending our time with us today, and we look forward to seeing you on a future webinar. Please stay safe, stay healthy, and have a great day. Bye, everyone.
Thank you so much.
Bye. Thank you so much.
Thank you.